Welcome to the Real Integrative Medicine Podcast. I'm Dr. Jordan Robertson, and I'm here to bring you the tools, insights, and strategies to take your health to the next level while using evidence-based integrative medicine. What's real? This is what we want to explore together. Research is ever-changing and not easy to interpret. We're bringing you the best that integrative medicine has to offer while sticking to the facts. Our mission is to elevate the practice of integrative medicine for clinicians and patients alike. Preventative solutions, nutrition, exercise, and sometimes supplements have a seat at the table in medicine, but only if we uncover real science-backed solutions. It's time to uncover what works and challenge what doesn't. Let's unlock your full health potential with an integrated approach. Ready to learn what's real? Let's dive in. All right, welcome to another episode of Real Integrative Medicine. I am so excited to have this conversation. Quite often when we talk about thyroid and thyroid health, we are educating people to get tested. We're also usually educating people around getting treated and not ignoring the symptoms that they're having that we think may be linked to hypothyroidism. Today's conversation about thyroid is going to be just a touch different, where we're maybe going to convince you not to be medicated in some scenarios. We're going to maybe convince some practitioners not to overtreat patients who have what we call subclinical hypothyroidism. I'd love to introduce our guest today, who is I'm going to say the most famous thyroid naturopathic doctor on earth, Dr. Alan Christianson. Alan, thank you so much for spending time with me today.
Hey, Jordan, glad to be with you. This should be a lot of fun.
I saw you speak a couple times actually over the last year, and I'm going to use the word relieved to listen to you speak about subclinical hypothyroid. This has always been an area for me with integrative medicine where I felt like we've kind of talked out of two sides of our mouth at the same time. We don't want patients to be over-medicated in so many areas of medicine. And yet, when it comes to thyroid, we almost give thyroid medication out like candy in the integrative medicine space. And when I heard you speak last and talk about, the newer research on subclinical hypothyroid, which we'll define for you in a second if you don't remember what that is, I was so relieved that you has changed your mind about prescribing, but also that you're on a mission to help clinicians get better educated about when to add medication and when to watchfully wait. I'd love if you could start us off just by talking us through your very extensive career working in the endocrinology space and in thyroid medicine.
Yes, thank you for that. I started my interest in this back in the early 90s. This is a time in which the conventional world and the natural world were even further apart. There was a lot of new ideas coming out in natural medicine that kind of made their way into the common understandings. Those from Broda Barnes, from Dr. Wilson were kind of new then. And I saw that this was a real phenomenon. The disease rates were just really on the uptick then. They went up radically the next following decades. So it became just a central focus of mine is, what's happening and what is being missed in the conventional world. But in the natural world, I saw even then that the idea of giving meds like candy and taking more and more meds, that it sometimes helped, but it also was sometimes harmful. So the thought was, how can this be done more selectively? And that really first came to my attention about 30 years ago now. And I founded the Endocrine Association of Naturopathic Physicians, and I've trained thousands of doctors worldwide on this, and it became just a real big passion.
So let's talk through maybe why there's so much discrepancy around diagnosis with a thyroid, because depending on who you ask, I think we change our mind about what we're willing to tolerate in blood work, which levels we want to intervene at. If we can just, for the general person who's listening, define some of those terms in terms of thyroid health and what is normal as far as thyroid function versus when do we start to worry about abnormal thyroid function?
Yeah, this is great. In some context, it's been argued right now that when people are searching online for Google or chat or whatever, health topics are among the top 3 topics. Within health topics, among the top 4 topics is thyroid disease. So this is a massive problem worldwide. And what's different here is that this is not just a matter of here's a natural treatment versus a drug. It's that here's a whole different perspective on when the disease is present. That's really unusual. We're not just saying here's a natural substitute. We're saying, here's a whole new way of saying, is this condition here or not? So conventionally, they've pretty well demarcated categories of normal thyroid function and then categories in which the thyroid has shut down. And in those cases, the gland is making too little of what the body needs. We call that hypothyroidism. So many things hinge upon words and definitions, right? So the term hypothyroidism is used in multiple ways, one of which is that. But that's not the only one. It's also used to categorize numerous laboratory abnormalities, which are not hypothyroidism. So when the gland is truly shutting down, the typical laboratory findings are that the feedback from the pituitary, the TSH, elevates. It's begging the thyroid to work. And this number is usually well above 20, way outside normal range. And then the measurable hormones coming from the thyroid, the T4 firstmost, is way below range. It's being yelled at to work and it's not keeping up. So this is true hypothyroidism, or it's called overt hypothyroidism. Now, there's another thing which is much more common, which is where the thyroid is working, but the signal telling it to work is higher than average. That's called subclinical hypothyroidism. It's not hypothyroidism. There's nothing that's missing here. It's just that there's a finding that's not typical. There's more of a signal than average. So those are the conventional guidelines. Now, what's different in the natural world is they've gone many steps further. That a lot of cases, even when levels are normal, we say, yes, but this can be a problem. This still may be hypothyroid if your TSH is high normal, if your T3 is low normal, if your body temperature is low, if your reverse T3 is high. And we can talk a lot more about these. And yeah, there's a real complex relationship between all these different levels and thyroid disease and thyroid symptoms.
You bring up such an interesting point around the, usually that conversation between conventional medicine or natural medicine is in the treatment, maybe methodology,
right.
Not saying yes, it's there and no, it's not there. Back in my very early days of social media, I had a post that said, if you want a conventional doctor and a naturopathic doctor to argue, just give them some thyroid lab work. And it's because funny. We would have a different answer to the same set of numbers.
Right.
And I think that's, I don't know if that's really helped the conversation over the last 10 years. But what impact do you feel like that's had, that we have such a different view on how to interpret the same numbers on thyroid lab work?
Oh, it's huge. It's huge. And the difficulty is there's two views that at first glance seem inseparable. So the one view, which is valid, is that many people who have these levels that are not a full-on shutdown, they can still be symptomatic, totally true. And they may have greater risks for thyroid problems, totally true. But we then assume that therefore, if this may have some thyroid connection, that therefore thyroid medications will be helpful. And that's the difficulty. So we can assume if there's anything off, if someone is symptomatic and they've got anything goofy about their thyroid levels, then thyroid medications are the best solution. And that last step, there's this classic old cartoon that you've probably seen to where there's these physicists with these arcane symbols, and finally a miracle occurs and goes over here, well, let's clarify this step. So that's a step that needs clarification. So you can have a problem with your thyroid, but it doesn't mean medications are going to fix that problem or make you feel better.
Yeah. And I think with all the different thyroid markers that we can check now, right? And I think where patients can get frustrated is when they see their doctor and they leave with two check boxes, right? TSH and T4. They can feel frustrated that that's the only thyroid lab work that is getting looked at, whereas they can read online or even see with an integrative practitioner that they would have many, many boxes checked off, right? To technically try and evaluate the same thing. Mm-hmm. Except the more boxes we check, the more likely we are to find an abnormal number. Yep. And so that, it's a bit of a disservice, I think, and I'd love to know your opinion on it, in that integrative medicine space where we're checking off 5 or 6 labs for looking for thyroid dysfunction in patients who have a normal TSH or have a normal T4, because it's almost giving us evidence that we need to act or do something if we find slightly off numbers in some of those other tests. And yet, those tests are not correlated with treatment, right? And fixing those numbers doesn't make people feel any better. I'd love if you could just dive into that a little bit for us.
There's so many examples of situations that are compelling and hard to sort out, but defy one simple rule. And one of those is if a patient is struggling, they're not feeling well, they've not gotten help before, it seems like it's always the right thing to do more tests or to be, seems like you're being more thorough or more caring or more trying harder to make a difference. There is a point at where when you're testing things and the likelihood is below some threshold, you will find results that are unusual but are not relevant. And you will eventually find abnormalities that will send patients on a wild goose chase to do treatments that aren't helpful, might be harmful. So we always have to balance those forces. And in natural medicine, I think we have a good sense of wanting to do well, wanting to try harder, wanting to think outside the box. What we may lack is a sense of healthy restraint or healthy skepticism or a realization that there's a point at where we're doing things that are excessive or counterproductive. They've got to be balanced.
Yeah, and I think that's hard because the symptoms of hypothyroidism are so abstract, right? Like patients have fatigue and they have weight gain and they have brain fog. And so when they feel dismissed or unheard or, they feel like they're previous medical encounters maybe haven't addressed some of these pieces, there's almost like this customer service pull where you're
Right.
like, well, we'll figure it out. We'll dive deep until
Yeah.
we'll turn over every stone. And that almost makes you feel like you should order more labs when it's hard. It's hard as the doctor, I will say this, to try and help patients understand where to show restraint with assessment because they want something to validate their experience on their lab work.
And who wouldn't want to think that the problem could be solved by just adding in another pill and maybe even a pill that's categorized as natural? So yeah, I totally get that. But yeah, between ordering more tests and then also doctors make it almost a stance of piety about how normal of a range they consider normal for all these different tests, how narrow of a range they consider normal. And it's become an arms race. Well, no, we check these more tests and these type of a range. And at some point, no one will ever not require treatment given these criteria.
That's right. There's like good, but then there's even better. And then
Right.
there's A optimization. And depending on which doctor you see, and this has always been my challenge in integrative medicine, without us having like good standard of care and good evidence that you could, if you just drive 5 more miles down the road, you might get a doctor that gives you medication for the same set of lab work or the same set of symptoms. And I think that's problematic because now we're talking about a drug and we're talking about something that's not without harm.
Right. So here's a big point that took me a long time in this space to wrap my head around is that we almost assume that if you're measuring a level of something that belongs in the human body and you're manipulating that by using a compound that's chemically identical, the same thing the body would make, and you're achieving levels that are normal, arguably optimal, it's almost an article of faith that has to be okay, that you have to be making this person healthier because now their levels are better, they're more normal. And yet the part that took me some time was that we can measure the most superficial facets of our endocrine system. There's many known unknowns and countless unknown unknowns below that. And just because measurably someone has normal levels, we've given them a bioidentical type hormone, that's not the same as someone doing that by themselves. That's not the same outcomes. It's not the same disease risks. So yeah, even if we give something that is like what the body would make, and even if we are at reasonable levels, which is often not, it's not the same as the body doing itself. Taking a hormone is not the same as making a hormone.
And what is the risk? Like, let's talk through that. So, for patients who have maybe been classified as borderline or just hypothyroid or on their way to hypothyroid, maybe they have elevated thyroid antibodies and a TSH that's creeping, climbing up towards a number we maybe don't find acceptable, but they also are tired. Like, what is the risk of us over treating that person or treating them too early? What does the research say about that?
Boy, great question. So the scenario you described, someone who has perhaps subclinical hypothyroidism and then Hashimoto's antibodies, when we look at this on aggregate, this is an important point too. The nice thing about the research is that we're looking at large group differences, which allows us to look at fewer variables. The drawback about natural medical practice is we've got a lot of variables. Now, that's a strength. We can help people doing a lot of good things, but it makes it a weakness in terms of evaluating an outcome. We can't say what did what, right? But at group levels, you can do that. So when the only difference is thyroid medication, medications don't help that scenario. They don't make people less tired. They don't make them lose weight. They don't cut the risk of further disease. Now, clinicians, when they're doing comprehensive, good, thorough care, people often feel less tired. They often will lose weight. But when the meds are the only variable, those things don't happen. So we got to put more weight on the other facets of care. So yes, that's what we're seeing from the big data sets, is that when that's the one intervention, there's not a clear benefit. And then in terms of overtreatment, so far, we're still talking about people who are given levels that are achieving normal ranges. But the data is strong that somewhere between a third to a quarter of those on thyroid medications are occasionally overtreated. And it's definitively clear that when they're overtreated, there's great risks for cardiomyopathy, heart failure, atrial fibrillation, cognitive decline, early death. And now we've got more data saying even when people aren't over medicated, even when they're achieving normal blood levels, they have worse health outcomes. We've got higher risks of 15 different types of cancers with normal thyroid levels. We've got double the rates of mortality. We've got greater rates of bone loss, all when they're not over medicated.
And I think that's such an important point. I almost want to just stop for a second, say what you said again. It's these are people who they were not frankly hypothyroid. So they were subclinical, borderline, and we treated them to within normal levels. So it's not like we overdosed them, right? Like that's a huge differentiation. We didn't give them so much thyroid hormone that it was measurable, that it was too much, or that it was pushing on some button that shouldn't be pushed on. And yet that treatment itself does seem to increase risk if we're giving it in someone who maybe quote unquote didn't really need it in the beginning.
Just to go deeper on that, so overdosing, earliest sign of overdosing is TSH suppression, TSH being pushed below range. So yes, even without that. Now, there are many in natural medicine who argue that TSH suppression is harmless, and that's a different discussion. It's not, spoiler alert, it's not. But even without the earliest signs of overdose, and this has been looked at in populations that are on a wide range of types of thyroid medication. So yeah, T4 only, natural thyroid, some combination therapies. And the best data we have is that it doesn't make a big difference, that when they're taken unnecessarily, there are risks that emerge, even with normal levels. So yeah, taking a hormone is not the same as the body making it by itself. And there's those to where this is life-saving, to where it's essential, to where it's necessary. This is not a good or bad type thing. But if it's not needed, you really want to find better ways to solve those same problems that are safer.
It's funny, when I've presented before to clinicians on some of the data around like no improvement in quality of life and no improvement in weight and no improvement in symptoms in patients with Hashimoto's who were treated, who were again, quote unquote, normal thyroid before, but we gave them meds anyways, that the way they feel didn't get any better. Right. And when I share that with clinicians, they almost don't believe it. And I'm like, well, that's never the only thing you do, right? You talked to them, you had a great therapeutic relationship, you maybe casually mentioned they should get more than 6 hours of sleep. Like all of those pieces were part of your treatment plan. But when we just give the thyroid hormone, the person doesn't actually feel any better. There's symptoms that we think we're chasing with the medication don't go away.
And something really shocking. So a difficulty about looking at the correlation between thyroid levels and symptoms, a big difficulty is that in most cases, we're looking at that in a biased population, a population that's already symptomatic. They're seeking out care. There was a big study that I mentioned in which people were just at a health fair, so they weren't there for particular concerns, and they were given thyroid tests and detailed symptom surveys. So the question was, random people, regardless of how they're feeling, how much do their thyroid levels vary, and how tightly does that correlate with symptoms? And what the study showed was that yes, as someone progressed through those stages of hypothyroidism, they got more symptomatic, totally true. But even those who were overtly hypothyroid, the rate of those who were asymptomatic was larger than those who were symptomatic. Specifically, those who had TSH scores averaging more than 20 and T4 scores below range, 83% were asymptomatic.
Which, to the point of why we even screen for TSH in a healthy population is that to that point exactly, right? People get their thyroid tested every year on their annual medical because we can't find the majority of overt hypothyroidism just based on symptoms alone, right? There's so many people that could walk around with dangerously low thyroid levels but not even know. So we screen for it. But then when we start to do this real big read between the lines on what we think normal is,
Right.
it means we've actually led to some over treatment of people who we would never have tested their thyroid otherwise. We screen because at a population level, it's doing more benefit than harm. It's only when our interpretation of those normal numbers starts to get, too nuanced that we maybe start to do more harm than good with that screening test.
Well, and a big point too it brings up is differentiating the body's compensations from decompensations. I've heard it argued that we've got somewhere around 9,000 or more biochemical pathways being juggled at any given point in time. And when there's certain abnormalities, I think we can be quick in natural medicine to assume that abnormalities are errors, are breakdowns, are things that have collapsed, basically. And that can happen, of course. But more often than not, they are compensations. They are ways in which the body is looking at all the known factors at play and making its best out of them, doing its best to really compensate. So yeah, I think we're quick to assume that the subtle abnormalities are, we found the problem, when this really may be one of the ways the body is doing a good job compensating for the various stressors it's sorting out.
I don't know if this is you or not, but if you're a naturopathic doctor or an integrative practitioner who prides yourself on being evidence-based, but don't have time to stay up to date with the research yourself, I have a solution for you. I'd love to invite you to explore and join the Confident Clinician, the only integrative medicine clinical decision-making tool that helps get research from PubMed into your practice with ease. We have built out exactly what you need to be the most efficient in your work, to be the best in your community, and to save you those precious hours that you're spending right now doing the research yourself. Joining with our premium membership gives you access to unlimited AI searches, gives you access to all of our previous database content, as well as our upcoming year of live delivered modules. You can check out more in the link in the show notes. I would love to see you inside of our community. We're making a huge difference in the way that practitioners practice integrative care and raising the bar for evidence-based integrative medicine. I hope you'll join us. And can you talk for a second about just the daily fluctuation in TSH? I meant to mention it earlier and we got off on an amazing tangent about everything else. But even when we take a snapshot of thyroid health, how accurate is that in terms of even understanding someone's total thyroid picture, given how much TSH and T4 fluctuate throughout the day?
Sure, yeah. So this is great in terms of both screening for disease and tracking those who are on treatment. So varies throughout the day quite a bit. TSH scores are calibrated for AM readings. Afternoon readings are quite a bit different. The normal peak is in the earlier times. They also vary quite a bit throughout the course of a woman's menstrual cycle, regardless of being on thyroid medication or not. So mid-cycle scores can be quite a bit different than they are at the very beginning or the end. Fasting affects that. The use of many common vitamins can greatly change the scores. The timing of thyroid medications can affect that as well. And then also, there are some who talk about these super narrow targets, and what they fail to appreciate is that even in the most perfect scenarios, the technological limitations of our testing allows for about 1.5 fudge factor of just reading to reading variability. So it's a good test, but there's a certain amount of variability that is normal, that cannot be worked out of the system just yet.
And I think even I've been guilty of this at points in my career where we had goals of particular numbers. And if I'd only seen the patient once, and I would say this is maybe early in my career, I only had one number to go on. It's not until I'll say you're seasoned veterans like I am now, where you'll have years of thyroid lab work on people and realize just how much fluctuation there is, even in the same person, even in someone who's relatively healthy, by all other accounts, that we'll see this fluctuation in that same number from day to day. I've even had patients take a requisition from me and a requisition for their annual physical and happen to go for their labs on the same day. And their TSH is different, even though it's been pulled minutes apart by the technologist. And so when we get so bent out of shape about numbers being within this small range,
right,
but the normal variation of that number is actually wider than what we're willing to accept, you can see how we would start to categorize people as being almost diseased, even though that is not true if we just took another blood sample.
Right. Multiple readings make a big difference. There was a time about a year and a half ago where a neighbor of mine was almost uncomfortable asking. She knew what I did, and we're friends. And her daughter was diagnosed with having central hypothyroidism. She had TSH scores that were non-measurable, and her T3 and T4 levels were non-measurable. And she had no other changes in pituitary function, no symptoms, healthy fertility, like no issues whatsoever. And they were wanting to do quite a bit of treatment with her right away. My recommendation was just test her again. Do nothing, just test her again. They did. She was fine. Now, I don't know if her prior readings were simply swapped or a complete error or what, but there's many, you can't put a lot of weight on any one single reading.
So when someone gets back some lab work that's maybe borderline, we'll call it, where their TSH is creeping up, it's not quite classified as hypothyroidism, but it's maybe above that optimal range. What should watchful waiting even look like? And how likely is it that that person will drop back into normal numbers if we just wait?
Yeah, that specific question, the last one, there have been studies on that. And 30 to 40% of the time, if we do nothing but retest in a few months, they'll be normal, doing nothing whatsoever. There's a lot of things we can do that are more informed, more helpful and specific than that. But even just doing nothing, oftentimes it improves.
Yeah, I'm glad that you said that. I wanted you to say that because I think it's such a good reminder that like this term, subclinical hypothyroidism, we've assigned this term to people, but 40% of them, maybe on the high end, spontaneously get rid of this issue if we just retest them at a later date.
Well, and again, there's talk about changing this, and I wish it would happen. It's actually not hypothyroidism. There's not a lack of thyroid hormone. It's categorized as such, but it's not clearly in that definition. It's not a disease.
So what advice would you give someone who's seeking support for thyroid? Like, let's say they are fatigued. They do feel like they've gained weight. They do have brain fog. And when they plug it into ChatGPT, it's saying, make sure you have your thyroid levels checked. Like, how should like a proactive person actually approach this, knowing that A, thyroid is not the cause of those symptoms a lot of the time, but also B, that we may not like jump the gun and give them medication right away. We still want them to be validated. We still want them to go through all the right steps. Like, how does someone navigate this now that we're not going to point our fingers at the thyroid maybe as often as we used to?
Well, there's some things to pull apart. There's first whether or not these symptoms are being caused by the thyroid. And that's worth answering, even if there are thyroid abnormalities. That still may or may not be a factor. And then the next question is if medications are helpful. If it is a thyroid problem, do medications help? They're separate questions. So these symptoms can be present and they may or may not be thyroid related. If someone's overtly hypothyroid, they can be. Now, they can be overtly hypothyroid, but still have other things that are causing symptoms and disrupting their thyroid, like various anemias or whatnot. So there's also multiple things that can go along with it. And furthermore, there's ways by which autoimmune thyroid disease can cause symptoms and risks regardless of one's thyroid levels. So there's more people that have marked thyroid autoimmunity than have overt hypothyroidism. And even with what everyone would call perfect levels, the autoimmune side of it can cause symptoms and can cause infertility and heart disease and various health risks. So that's still relevant. And then the other step is that with thyroid disease, there's a really high rate of many other tag-along conditions. So I mentioned anemias, there's autoimmune gastritis that's very common. We can see higher rates of parathyroid disease, more rates of sleep apnea, fatty liver. Even just simple extra body weight can cause symptoms. Many don't think about that. But all these other factors can also be both causing symptoms and making thyroid changes more likely. So those are other things to think through. When we've really identified that the thyroid is off, there's autoimmune levels, there's overt disease or whatever else, probably the biggest single thing that's relevant for someone is getting to a healthy range of iodine intake.
And I've seen that, the conversation about iodine in this, in the integrative medicine space has swung all over the place and maybe still sits on two very different poles. What does the research say right now around iodine supplementation and intake with respect to thyroid?
Very cut and dry. So people have different genotypes regarding iodine tolerance. And those who are prone to thyroid disease whether it's thyroid cancers, Graves, Hashimoto's, nodules, there's about 12.5 genes that are correlated with that. And these are all genes that affect iodine metabolism, the deiodinase enzymes. So basically in the modern world, adults prone to thyroid disease have a narrower tolerance. They can be negatively affected by iodine more easily. So it's not a good thing or a bad thing. It's that some people can't tolerate the slight excesses. And in terms of numbers, that's somewhere around 200 micrograms per day. And we see this globally from many large studies looking at changes after iodine fortification. Once a culture moves above about 200 micrograms, the rates of these diseases go up. So that's the main factor there. It's been argued in some recent studies that we need to differentiate causes from contributors. Causes can make a disease happen when nothing else is there. Contributors can make it a little more likely if it's about to happen anyway, but they can't do it by themselves. Now, there's countless things that in natural medicine we call causes of thyroid disease that are probably better called contributors. It's been argued that causes are really just four. There's age, gender, genetics, and iodine exposure. And of those, there's not a lot we can do about age, gender, and genetics. They're more existential causes. They're not things we really have control over on a day-to-day basis.
And yet, for many years, I've always been frustrated in integrative medicine where we know that there's arrows or cofactors of various vitamins or nutrients or minerals that seem to influence hormone production. And we assume that giving more of that nutrient is going to drive better production, right? And we see this in, the female health space often where it's like, oh, B6 helps with this. So obviously we give B6 if someone has PMS. And it's like, whoa, that's not how that works.
Right.
And I think the iodine conversation was similar with thyroid, is that for a long time we went, well, iodine does a thing for thyroid hormones. And so if you are at risk of low thyroid or if you have hypothyroidism, we should give you more iodine so that that arrow is more effective. And, turns out now that is the complete opposite of what we should do in patients with thyroid disease.
Yeah, that's a great point you bring up. And it does generalize quite a bit, so the best analogy I've thought of is like keys to a car. We often think about ways by which if someone's B12 deficient, they're tired. Totally true. If the keys are missing, the car won't move. Totally true. Once you got keys in the car and the car's going slow, 100 new sets of keys won't make your car faster. That's no longer, they're rate limiting steps. So when they're lacking, things don't work well. But once they're at sufficiency, their job is fulfilled. And if things aren't working right, it's some other factor. And iodine has another layer on that. It's different from other nutrients. Other nutrients, basically your body is bathed in your blood and your cells get what's there. But iodine, there's another level of control. So you block and you pump in what you want. And the paradox here is that once you get above a bit of a window, you block it. So you get too much current in your house and you blow the fuse. And now the lights are out. So now too much power is just like no power, right? It's the same thing with your thyroid. Once you're above your personal window of tolerance, you stop the uptake. You stop to make your thyroid not make fatal amounts of hormone. And suddenly all these signs of a lack of thyroid hormone or low thyroid function can be the same from too much or a severe deficiency of iodine.
Yeah, that's such a great analogy. I'm glad that you put it that way. And I truthfully, once I looked at the population data that it's like the more iodine, the more thyroid disease you have. I don't think I've ever prescribed iodine in my life, but I've never been able to really describe it to clinicians why it's a problem when it seems like it's an important cofactor as part of thyroid function.
It is an important cofactor.
Last-ish question for you, Alan, for people that are listening or clinicians who are listening who are on medication, right? So who now are on medication, and we're not going to tell you what to do with your medication. We're telling you to go back and talk to your practitioner about your medication. But is there hope for anyone to ever get off their medication if they have been on it for subclinical hypothyroid? And what does that look like? And in your experience, what are the outcomes with people when they choose to discontinue their medication after they've been on it for a while?
Yeah, this is such a logical question. And in terms of the progression of research, with all the studies showing that most who are on the medicine don't need it and that there are side effects to it, that question has been addressed and is the topic of more ongoing research as well. The consensus is that somewhere around, and I'm sorry, I should back up a step. So far, the limitation of most of the studies has been that they have been very different groups pooled together, many of whom were overtly hypothyroid when they were put on medication. and most of which were subclinical, but some were not. And in natural medicine, most of our patients weren't even subclinical. Most were what could be called suboptimal or normal but not optimal. So the studies I'm going to cite are large mixes, many of whom were overtly hypothyroid. Generalizations have shown is that about 80-84% can successfully take less medication and do fine, successfully normal levels, no negative changes in symptoms, and about half of that subset can successfully come off entirely. In terms of action steps, the newest studies do talk about avoiding extra iodine. Thyroid meds contain rather high amounts. And so if the amounts between the medicine and the diet are excessively adding together, it makes it harder for the body to respond and harder for the thyroid to improve. So many of the studies now will recommend avoiding any extra controllable sources of iodine in doing so. But yeah, roughly 84% can lower, and about half of them can come off successfully. And clinically, I've seen this a lot firsthand, and I get tons and tons of feedback from my readers. Current record is someone who's been on medicine for 45 years and now no longer on any and doing fine. And yeah, it's a, I don't know, at high level, for so many years when I started practicing, the question I'd always hear the most is, can I quit medication? Can I have my body work by itself again? And in the years in which I was more of an active prescriber in natural medicine, my thought was always, let's get you healthy and feeling better. And if that happens, it's fine. And I didn't think that it was as possible or as likely. And so I didn't put as much energy into it. But it's the most natural reaction people have. They don't want to be stuck on a medication forever. They want their bodies to work by themselves, and they should feel that way.
That's such great advice. Yeah, I love that, that you can combine both the research with also like your decades of clinical experience. I won't say that I had a ton of experience getting people personally off of medication, but I was always so curious, and not because I didn't try, but because I just didn't have a huge percentage of my practice that was thyroid. But I was always curious, when I had worked with mostly women through many periods of their life where there was different demands on their thyroid, like pregnancy, like that transition in perimenopause. If we were ever misinterpreting those events and the impact that they were having on thyroid, then prescribing, right? Where maybe if we had just watchfully waited, that person would have returned to normal or had more optimal levels at a later time. I met so many people who were prescribed thyroid hormone after pregnancy and told that they would never be able to discontinue it.
Right.
It's nice that the dialogue around this is changing, that, it's a bit more hopeful that maybe people would have to use thyroid at some point in time.
Well, and that's how it seems, both in terms of the literature and also the feedback that I've received. And I don't know, it really fits the narrative that I've resonated the most with, is that the body is pretty amazing. And when it's given a chance, it can do pretty cool stuff. It can fix itself in ways that are often unexpected.
Thank you so much for spending time with me. I just love this conversation. I think the last time I saw you spoke, I tracked you down in the hall and just said thank you so much for your contribution to naturopathic and integrative medicine. It makes a profound difference to hear someone at your level, change your mind, be able to be nimble with the research and pivot our practice based on what the standards of care suggest at this point. So I'm so grateful for the conversation, Alan. How can our listeners find you, find your resources? You put so much good stuff out there into the world.
Just Alan Christianson on Google. I'll show up on my sites and social media. Pretty easy thing.
Amazing. And are you working on any big projects right now that we should pay attention to?
I'm kind of toying between a few options. Nothing clear at the moment, though.
Well, thank you so much for spending time with us. I really appreciate you.
Thanks for having me.
That's it for today's episode of the Real Integrative Medicine Podcast. I hope you're feeling inspired, informed, and ready to make changes that truly support your health. If you found value in today's discussion, don't forget to hit subscribe, share this episode with someone who needs it, and leave a review. It helps us reach even more listeners just like you. Your health journey is personal and it's powerful. Let's keep building on the knowledge to give you the confidence you need to thrive. It's important to remember that the Real Integrative Medicine Podcast is for educational purposes only. Be sure to talk to your doctor before making any personal health changes. This podcast isn't intended to diagnose you, and no doctor-patient relationship was formed by listening. We'll see you next week.